Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at exam questions in one clinical course. Today we're going to be looking at the season 1 finale of surgery. If you haven't yet subscribed, please subscribe to the channel, drop a like, drop a comment, show some support, share the link, and spread the word. And a big congratulations to the channel for having unlocked the community button on the webpage. So if you see that, and please drop your votes on what you would like to see on the channel next as we conclude exam week this coming week, and we shall be moving on to x-ray week. So if you haven't yet subscribed to the channel, please subscribe, tell a friend that it's soon going to be x-ray week on the channel, among many other things to come. So grab your piece of paper, grab your pen, and let's go. So beginning with our question 1, define excised and incised wounds. Part B, describe briefly physiology of healing of excised wounds. And part C, list complications of wound healing. So I'll give you 5 seconds to think through this. Okay, so here comes the answer. So remember that excised wounds are just pretty much tissue injuries that you're going to create by the act of cutting out or severing or removing undesired tissues from the body. And in contrast to this, incised wounds are going to be tissue damage or tissue injuries that are going to be created by the act of cutting into tissues in order for you to gain access or even to enter a certain cavity in the internal part of the body. Then describe briefly physiology of wound healing. Remember that wound healing of excised wounds is pretty much going to be happening by fibrosis, and it's going to result in a wide scar that is often hypertrophied and contracted. There could be some re-epithelialization that occurs from the remaining dermal elements or the wound margins. But remember, largely wound healing happens in 4 main stages. So let me give you a scenario so that you get this into perspective. Suppose you're cutting vegetables, and then as you're cutting that food, you end up cutting your finger. So whenever you cut your finger, there are blood vessels that are damaged. So remember that when blood vessels are damaged, almost immediately they undergo vasoconstriction because certain chemical factors are produced, such as endothelin, which cause vasoconstriction. In addition to this, the middle layer, the tunica media of the blood vessels, is going to undergo some contractions and some spasms, some local neural reflex that's going to decrease the size of the lumen. This is an initial transitory vasoconstriction, but remember, this is later going to lead to vasodilatation that's going to lead towards into inflammation. And remember, at the same time that this is happening, you're going to be having a lot of things like platelet activating factor being released. You're going to be having things like ADP that is being released that are going to enhance platelet activation and platelet aggregation, and eventually platelet derived growth factor is also going to be released. So you refer to this stage as the stage of coagulation or hemostasis. It is almost immediate. Then the next stage is the stage of inflammation, which usually happens after the vasodilatation that has happened, and it lasts for roughly about 4 days. So you're going to recruit these inflammatory cells that are going to reach this site of injury. Initially, you're going to have neutrophils getting there, then macrophages are going to get there, and then they're going to be secreting fibroblast growth factor, which is responsible for angiogenesis, which is the formation of new blood vessels. It's also responsible for skeletal development as well as removal of the tissue debris, because as long as there's tissue debris, the wound will not heal. Then later on, lymphocytes are also going to be secreting some inflammatory mediators and oxygen radicals. There are going to be a lot of implicated interleukins as well as cytokines such as tumor necrosis factor alpha. Then the next stage of wound healing is known as the stage of proliferation, or you can call it the proliferative stage or the stage of fibroplasia. This is going to be lasting from about 4 to 21 days. And here there's going to be formation of granulation tissue. Remember the P's of granulation tissue. If you do not know what the P's of the granulation tissue are, please comment in the section below and we shall tell you. Then there's going to be fibroblast that's going to now deposit collagen type 3, and the capillaries are going to also provide the nutrients for this wound to heal adequately. Then you go to the next stage, which is the stage of remodeling, which takes from 3 weeks to about 18 months. So here there's going to be maturation of collagen, and how this collagen matures is that there are going to be some cross linkages that are going to be happening so that you can create this tensile strength of the scar. Remember that completely healed tissue has about 80% of the tensile strength of compared to healthy tissue. Then there's also going to be differentiation of fibroblasts into myofibroblasts, which have this contractile elements in their cytoplasm and are responsible for the contraction of the wound. Then eventually an enzyme that's known as collagenase that uses zinc as a cofactor is going to catalyze the conversion of type 3 collagen, which is going to be replaced to type 1 collagen, and then blood vessels are obviously going to atrophy. Then list complications of wound healing. So you have early complications versus late complications. Early complications, you could have wound infections, which could lead to septicemia, which could even cause septic arthritis, especially in close proximity to the joints. You could have late complications such as wound dehiscence or wound rupture. You could have contractures if they're occurring in joints. You could have keloids, and you could have hypertrophic scars. Remember the main difference between keloids and hypertrophic scars is that hypertrophic scars, the excessive proliferation of scar tissue is going to be within the margins of the wound, while keloids exceed the margins of the wound. And often keloids are not associated with trauma. They may be associated with trauma, but hypertrophic scars are almost always associated with trauma. Then you could also have Magellan's ulcer, which means that this non-healing wound has become malignant. Question 2. Answer the following questions. Classification of head injury. Discuss the value of the Glasgow-Coma scale in head injury. So I'll give you 2 seconds to think through this question. Okay, so here comes the answer. So remember that head injury can be classified in many ways. One way in which we classify head injury is what is known as the general classification, or you could think of it as the mechanism of injury. You could have open injury or penetrating injuries. This could further be subclassified as high missile injuries or high velocity missiles and low velocity missiles. A high velocity missile would be something like a rifle. A low velocity missile would be something like maybe a catapult, or rather a shotgun. Then closed injury, which could also be referred to as blunt. Then head injury could also be classified according to the severity. This is where we use the GCS, which is the Glasgow-Coma scale. This is a scale that is used to assess the level of consciousness. So if you get a score that is between 13 to 15, so 13, 14, and 15, that means this person has mild head injury. If they have a score of 9, 10, 11, and 12, they have severe and moderate brain injury or head injury. Then if they have a score that's less than 9, meaning 8 and below, then they have severe head injury. Then you also have a morphological classification according to the injury that is present. So it could be fractures, it could be focal intracranial hemorrhage or focal intracranial injury. There could be diffuse intracranial injury. Then an alternative classification would be pathological classification, which classifies head injury as primary, which is obviously inherently due to the trauma that has been there. For example, it could be fractures, it could be bleeding, it could be a focal bleeding or focal injury or diffuse injury. And then secondary head injury, these are usually coming about as a result of other things that may cause the patient to deteriorate. Things like hypoxia, things like hypoglycemia, hypotension, hypothermia. So these are all the things that should be addressed in the management of a patient with head injury. Then part B, discuss the value of the GCS in head injury. So remember that this Glasgow-Coma scale is a tool that's going to be used to assess the level of consciousness. So it's going to be ranging from a minimum score of 3 to a maximum score of 10. It's going to consist of 3 parameters. There's what's going to be known as eye opening, which is scored out of 4. The maximum you can get is a 4 out of 4. The minimum you can get is 1 out of 4. I'll show you the actual divisions that are there in the next slide. Then the next response is the best verbal response, which is scored out of 5. The maximum you can get is a 5. The minimum you can get is a 1. Then you have the best motor response, which is scored out of 6. The maximum you can get is a 6. The lowest score you can get is a 1. So what you do is you summate all the scores and then you score them out of 15, the lowest being 3 out of 15 and the highest being 15 out of 15. I'll show you on the next slide how exactly we do this. So remember that this GCS is going to help us in the classification of head injury according to severity, like I've already talked about, where you have mild head injury between 13 to 15, moderate head injury 9 to 12, and severe head injury, which is less than 9. That's a Glasgow Coma scale that's less than 9. Another thing the Glasgow Coma scale can help us do is that in head injury patients, it can help us determine whether this person needs immediate intervention. If we get someone who has a Glasgow Coma scale of 9 versus someone who has a Glasgow Coma scale of 15, you're obviously going to be attending to the person with a 9. So in essence, it helps us with triage of the patients. Then another reason is it also helps in determining whether this person may need to be admitted or not. If the rule of thumb is this: if the Glasgow Coma scale is deteriorating, or the Glasgow Coma scale isn't improving, or the Glasgow Coma scale is low, then that's going to warrant admission for the patient. But if it's consistently high, then of course they may need to be discharged. But only do this if you have ruled out any things that may cause the patient to deteriorate, because there are some conditions that may have what is known as a lucid interval or a lucid phase, where a patient may actually just be fully awake and then all of a sudden they suddenly deteriorate and then they become worse, and some patients can even die. Then another thing that's important in GCS, especially in head injury patients, it also helps us in assessing the effectiveness of the treatment. What do I mean by this? If you are given the right treatment for this patient and you are doing everything that you're supposed to be doing, then the GCS is obviously supposed to be improving if there are no other underlying conditions or the severity of the injury isn't as bad. Then another thing is that it also helps us with determining the frequency of monitoring the patient. Of course, patients with a higher GCS may require less monitoring frequently as compared to patients with lower GCS. Then of course, it also helps us with prognosis if it's done very, very early. So if it's done in the first few hours, then you can monitor or you can tell the prognosis of the patient. If it's done very early, then you can tell whether this patient is going to have a good outcome or bad outcome. But of course, that also largely depends on the management that you're going to be instituting in this patient. Here is how you do the Glasgow Coma scale. So you have eye opening, you have verbal response, and you have motor response. Eye is out of 4. So if the patient opens their eye spontaneously, you give them a score of 4. If the patient opens in response to verbal stimuli, you give them a score of 3. If they open in response to pain, you give them a score of 2. If they do not open their eyes at all, you give them a score of 1. A different scale is used in children under the age of 5. That's known as the Blantyre Coma scale. Please look that up and know how to use it, especially for those that are planning on going to pediatrics. Then you have a verbal response, which is scored out of 5. So if they are oriented and they are oriented to time, place, and person, then you give them a score out of 5. If they are confused, they're having a confused conversation, you give them a score of 4. If they are giving you inappropriate words, you give them a score of 3. And if they're making incomprehensible sounds, which are murmurs and groans, you give them a score of 2. And if there's no sound at all, you give them a score of 1. Then motor is scored out of 6. So if they obey commands, simple commands, you give them a score of 6. If they're able to localize pain, you give them a score of 5. If there's flexion or withdrawing from pain, you give them a score of 4. And then if they're in a characteristic position or a posture, which is known as decorticate rigidity or decorticate posturing, you give them a score of 3. If they're in decerebrate rigidity, you give them a score of 2. And if, of course, there's no movement at all, you give them a score of 1. And then the total is summed out of 15. Then question 3, discuss briefly the WHO protocol for management of dog bites. So I'll give you 5 seconds to think about this question. So here comes the answer. So treatment of dog bites largely depends on following factors. Number 1, the category in which this is going to fall under, especially under the WHO protocol, which I shall show you in the next slide. Number 2, the depth of the bite and the nature of the dog. Was this dog stray? Was this dog tamed? And if it was tamed, was it vaccinated or was it unvaccinated? So generally when the patient comes in, you're going to be assessing, of course, doing first aid. So you're going to be assessing your airway, if the patient is breathing, if they gain venous access, okay? Check for any neurological disabilities. And then you're going to obviously give this person some tetanus toxoid about 0.5 or anti-tetanus toxoid about 0.5 mils over the deltoid as an intramuscular injection. You're going to decontaminate the wounds. So note the bite marks and wash them out with a lot of water. You could also use soap. If you're in a hospital setting, you could use water, normal saline rather, and iodine. Give this person some analgesia, dress the wounds, and cover them on broad-spectrum antibiotics, which is coamoxiclav, which is amoxicillin, and clavulanic acid. Or you could use doxycycline in combination with metronidazole. For patients that are allergic to penicillins, the alternative is doxycycline. Then you could also use other broad-spectrum antibiotics. You also have anti-rabies virus that is actually supposed to be given. So the dosage is about 1 ml over the deltoid or the lateral aspect of the thigh. It's given as an intramuscular or intradermal. If you're giving it intradermal, use the smaller doses. So you could give a short course or a full course depending on the level of exposure of this patient. So the short course is given at 0, 3, and 7 days. The full course is given at 0, 3, 7, 14, and 28 days. Then, of course, rabies immunoglobulins can be given, and these only just give you passive immunity. Then prophylactic measures are only effective within the first 10 days of the bite. So here's the protocol. So you have category 1, category 2, category 3. So if it's a lick, then if it's a stray dog, you reassure the patient. So just your reassurance. If it's a tamed vaccinated dog, you reassure them. If it's a tamed unvaccinated dog, you reassure them because the skin is completely intact. So there's no way in which the virus can get access to your body. Then if it's at category 2, which is a superficial bite, if it's a stray dog, then you give them first aid and you give them the full anti-rabies vaccine. That's the full course. If it's a tame vaccinated dog, then you see the vaccination certificate that they have gotten from the vet. And of course, give them some first aid and observe the dog for 10 days. And then if there's nothing wrong that happens, then you might as well be fine. Then if it's tamed and vaccinated, then first aid for this patient and observe the patient for 10 days. Then with category 3, which is a deep bite, if it's a stray dog, first aid, give them full anti-rabies vaccine. You want to perform some wound debridement. You would also give this person rabies immunoglobulin. If it's a tamed vaccinated dog, just first aid, give them a short course of anti-rabies vaccine, wound debridement, as well as rabies immunoglobulins. If it's unvaccinated, first aid, you give a full course of anti-rabies vaccine, wound debridement, as well as rabies immunoglobulins. Question 4. How much fluid are you going to give a 3-year-old child with 20% burns in the first 48 hours? Part B. When would you decide to perform a blood transfusion in this child if need be, and why? So I'll give you 2 seconds to think through this question and then give me your answer. Okay, so here comes the answer. Given that we're not really told how much this child weighs, we could actually estimate the weight of this child using the following formula. So you get the age of the child, you add that to 4. The answer that you get from here, you multiply that by 2. So this child is 3 years old. So 3 plus 4 gives you 7. 7 multiplied by 2 gives you 14 kg. So remember that this child is roughly around 14 kg. And remember how we calculate the resuscitation fluids in the first 24 hours? We say 4 mils multiplied by the percentage of the burn, which is 20, multiplied by the weight of the child. So 4 multiplied by 20 multiplied by 14. 4 by 20 multiplied by 14 gives you 1,120. So half of this, which is roughly around 560 mils, is going to be given in the first 8 hours from the time the child was burnt. Not from the time the child presented to the hospital, but from the time the child was burnt. Then the remainder is going to be given in the last 16 hours. There's only a problem if the child presents 8 hours after they were burnt. Now I'm really curious to find out how exactly you would manage this type of a child. So please drop a comment in the section below on how you would manage a child that comes in 8 hours after they have been burnt. How exactly would you give the fluids? Then, of course, maintenance. Remember, in the first 10 kg, you multiply that by 100. The next 10 kg, you multiply that by 50. And the remainder is multiplied by 20. So 10 kg multiplied by 100. So it means we're only left with 4 kg because this child is weighing 14 kg. So 50 multiplied by 4, and you sum the total, or you sum the answers, and you get a total. That's 1,200 mils on day 2. So this is Ringer's lactate given as intravenous, and then you could add some dextrose to this regimen on the second day because the child may not necessarily be eating. Then when will you decide to perform a blood transfusion in this child if need be, and why? We do not give blood to people with burns in the first 48 hours. The reason being that this person has had extensive injury in their body. They have released a lot of cytokines. There's a widespread inflammation that's going on. So there is what is referred to as a systemic inflammatory response syndrome. So you have all these cytokines and all these interleukins that are flooding into the system, and they're causing certain changes on certain structures. Blood vessels are affected. So these blood vessels are going to vasodilate. They are also going to increase in their capillary permeability. So there's going to be endothelial retraction and endothelial contraction. So to increase the capillary permeabilities. Therefore, if you were to actually give this person blood, the fluid component of the blood would actually exit the bloodstream, leaving behind the cellular component that would make the blood more concentrated and would make it more viscous, making it easier for thrombi to form or the blood to be sluggish in its flow. That's why we usually wait for after 48 hours. Station 5 or question 5, which is indeed the last question in this season finale. Part A, principles, write short notes on the principles of management for gas gangrene. Part B, list lower urinary tract symptoms. So I will give you 3 seconds to think through this. And here comes the answer. So with gas gangrene, remember that gas gangrene is caused by the species Clostridium perfringens, and it can be managed both medically and surgically at the same time. So when the patient comes in, you obviously want to oxygenate this patient, you want to gain venous access, you want to give them intravenous fluids, correct any electrolyte abnormalities. You want to administer tetanus prophylaxis. You also want to administer intravenous broad-spectrum antibiotics. So you could combine penicillin plus clindamycin or vancomycin or any other much stronger drugs, even ceftriaxone and metronidazole, as well as provide analgesia for this patient. You want to give this patient high oxygen, so you want to put them in a hyperbaric oxygen therapy, so a hyperbaric chamber, and of course use hydrogen peroxide for the wound care because Clostridium perfringens does not really like an aerobic environment. So the hydrogen peroxide creates an aerobic environment. So surgical management, of course, is going to include wound debridement and excision of the dead tissue, but ultimately an amputation may need to be undertaken. So what are the lower urinary tract symptoms? They could largely be divided into 2 main groups. They are irritative symptoms and the obstructive symptoms. Irritative symptoms include things like increased frequency, increased urgency, urge incontinence, nocturia, dysuria, and hematuria. Then obstructive symptoms are going to include things like a poor urinary stream, hesitance, intermittency, terminal dribbling. You could have urinary retention, straining to void, incomplete voiding, as well as overflow incontinence. And remember, these are largely caused by mainly bladder outlet obstruction, and you should be able to know the different causes that are going to be leading to bladder outlet obstruction. Thank you for taking your time to listen to this episode on MK's Exam Secrets. If you haven't subscribed, please subscribe to the channel, drop a like, drop a comment, show some support. We're leaving no one behind.